Okay, chapter 31, environmental emergencies. We're going to be talking about hyperthermia, hypothermia, water emergencies, and other sort of things like that. So let's jump right into it. All right, we're going to start with exposure to cold. All right, so first we got to realize how the body loses heat. There's about 5 ways that the body is going to lose heat. The first is called conduction. This is when there's direct contact with the body. For example, if you were outside and you put your bare hand on a very cold railing or something that was made out of metal or like a flagpole or something, the heat is going to transfer from your hand to that cold metal. If the person was in water, then the heat, obviously, wherever the water is in contact with the body, it is going to directly transfer that heat into the water. The second method is convection, and that is air, basically, or like wind chill, making you cold. It's carrying the heat away like that, making the person cold. Radiation, the heat radiates off of the body, and it's basically picked up by the air or water. The heat radiates out there. So obviously many of these things are happening at the same time, conduction, convection, radiation, things like that. Evaporation, this happens when we sweat or when we get wet. The surrounding air evaporates the water and cools the skin where the water is there. We lose body heat that way as well. And then there's respiration. We actually lose body heat through exhaled air. So those of you who have glasses, if you like kind of huff on your glasses to make them foggy to wipe them off, that's the heat that's coming out there when you're doing that. So when we're exhaling, we're actually losing body heat. Here's a picture that shows different mechanisms of heat loss. Radiation, as you can see, it's just again the heat radiating out into the atmosphere or nearby objects without actually touching them. Convection, body heat is lost to the surrounding air. Respiration, heat is lost through exhalation again. We get colder, obviously, when we inhale colder air too. But we lose heat on exhalation. There's evaporation. That's when we're sweating or the skin gets wet, and it results in body heat loss when the liquid evaporates. And conduction. Body heat is lost when there's direct contact with an object. Okay, let's talk about hypothermia. Remember our suffixes there. Hypo means below, thermia means heat. So it's our below our normal heat there. Therm means heat, actually. So hypothermia is when somebody's body temperature drops to below normal levels. Exposure to cold does this, and somebody can lose body heat through any of the 5 methods that we just discussed. When somebody has hypothermia, their body is not able to regulate their temperature properly in order to maintain that normal heat, that core temperature that we have. If it gets really bad, it can kill you, definitely. There's some things called predisposing factors. These things are, it makes somebody less able to maintain their core temperature, to maintain their body heat. So if somebody has injuries, maybe they're bleeding, if they have chronic illnesses, like for example, if they're diabetic and they're hypoglycemic, conditions like that. Geriatric patients oftentimes have cardiovascular issues, and so it makes maintaining their body temperature, their core temperature, even more difficult. And then pediatric patients, especially very young children, infants, They have a difficult time maintaining their core body temperature because they have, generally speaking, more surface area. Their skin is covering more surface area than an adult's is, and so they lose heat very quickly. Also, pediatric patients, they don't have the same muscle mass as we do, and so they can't shiver as much. Shivering is a compensation method your body uses to maintain heat. Whenever we're using our muscles, the actual act of using muscles, it creates heat in the body. And so when you're shivering, it's your body saying, hey, we're a little bit too cold here. We need to bring up our temperature. And so when you shiver, the muscles are quickly twitching like that, and it's generating heat. So because pediatric patients, especially very young ones, don't have a lot of muscle mass, you can't shiver for very long. And that means they can't maintain their body temperature as well. So we want to talk about obvious and subtle exposures. So uh, obvious exposure means somebody is outside in the cold for a long time, right? They're wet and it's cold outside, things like that. A subtle exposure could be maybe it's somebody that an elderly person fell out of bed and hurt their pelvis, right? And they can't get up, and so they've been lying on their cold wood floor all night. That may be like a more subtle exposure there. All other subtle exposures. So if somebody has been drinking a lot of alcohol, it makes it more difficult to maintain body heat. If they have underlying illnesses or injuries, it can make it harder to maintain core temperature, like we've said. Overdoses and poisonings. There's major trauma. If there's a resuscitation outdoors, if it's cold outside, if somebody's laying on cold pavement and you're trying to perform CPR on them, that is an exposure there, and obviously decreased ambient temperature. So it's just cold. A lot of like elderly folks, if they're living alone, maybe they can't afford to heat their house properly, and it's just that much colder in their place. And so if they're not able to move, if they've hurt themselves, if they're on the floor, that can be an exposure as well. So to touch on geriatrics again, um, the effects of cold happen much quicker with an elderly patient than it would a younger adult or somebody like that. It happens very quickly. So as we said, older folks, they may have be living on fixed incomes, may have unheated rooms or homes, or they're kept too cool just because they can't afford to heat them. So they have slowing metabolism, slowing body systems. They're losing muscle mass as they get older. All these things combined, along with any underlying illnesses they may have, that may contribute to them not being able to maintain body temperature in colder environments. So you've got to keep that in mind if you do have, let's say, like as that example we've already used, if you have a patient that's been lying on the floor all night before they've been discovered or able to get to a phone or something like that. So maybe they have the injury that's kept them on the floor, but keep in mind maybe they're hypothermic because of it, because they've been on the floor all night, things like that. So it's something to keep in mind with older patients. As we discussed, pediatric patients, they have larger skin surface areas in relation to their body mass. It's much larger than ours is. And so they lose heat quickly, and they have a harder time maintaining their core temperature because they're unable to shiver as much. They don't have that muscle mass like we discussed. All right, so when somebody has generalized hypothermia in the early stages, we're going to have the shivering. That's one of the first things that we get when our body starts to get cold. As we move into it, we're going to get some numbness or reduced or lost sense of touch, especially in our extremities there or face if it's exposed. A stiff or rigid posture. Somebody's walking around like they've got like a back brace on, basically. As we start to get colder and colder, might see some drowsiness there, and then we can see breathing changes as well as pulse rate changes. So we can have some rapid breathing on the pulse, or we can have all the way on the opposite end. We can have a slow or absent breathing as they get colder there as well. The loss of muscle coordination, you get joint muscle stiffness or muscle rigidity. I'm sure we've all been out in the cold enough where our hands are really cold, and it makes making a fist or grasping something that much more difficult. As the person gets colder, we're going to have level of consciousness changes. So we can have a decreased level of consciousness or even unconsciousness there. We'll have cool abdominal skin temperature. Now, what do you think? It says abdominal skin temperature. Why does that make a difference? Well, as we hopefully are thinking about when somebody gets cold, our body is going to be using compensation mechanisms to keep our vital organs perfused and warm, and so we don't have as much blood flow going out to the extremities, and so they're going to get colder first, the extremities. And so when we're checking somebody's skin temperature, we want to touch their abdomen because that's where the body's putting all the blood into there. So a cool abdominal skin temperature is a good sign that somebody's hypothermic. Now, somebody can have red skin or pale skin or cyanotic skin. If it's cyanotic, obviously it's a little bit bluish gray, and they can. That means obviously the oxygen's not getting there. Pale, less oxygen is getting there, and then red skin, the body's still trying to get some heat to the skin area there. All right, so let's talk about how we rewarm people. There's two options for us. There's passive rewarming and there's active rewarming. Passive rewarming is what we're going to do most of the time there, and that's basically it's if they're wet, take off the wet clothes and then cover them up with blankets. Okay, cover them up with multiple blankets. Take the heat in the back of the ambulance and jack it up. Let's get that high. It's going to warm back there. Right, but we're not going to be rubbing them. We're not going to be applying any heat sources or anything like that. We're letting the body slowly and almost naturally get back to its normal temperature there. This has many benefits to it as opposed to the active rewarming, which we'll get to in a second. So basically, for passive, if they're wet, get the clothes off, dry them off, and cover them with blankets. Those space blankets are really good. Those are the ones that they look like tinfoil. They're very thin. They're silver. They're shiny. They reflect a lot of heat back. So if you have those, most ambulances do, is you get the patient out of their wet clothes, you dry them off, you put that space blanket over top of them to radiate, to reflect that heat back to them, and then cover them with other blankets on top of that. Active rewarming is actually applying heat sources to the patient. So basically for us, that's going to mean heat packs. And where you want to do it is you've got a few places here. We want it, the places that we're going to put them on are the neck, okay, on either side of the neck, under the armpits, and in the groin, and then on the sides of the chest as well. What this is going to do, especially at those junctional places, right, at the neck, in the armpits, in the groin, we have large arteries and veins there. So our goal is to be warming the blood that's passing by there, that's going first, more importantly, back to the core of the body. The blood is going to be cooled and cold as it gets out to the extremities, and so we want it to be warmed as it's going back to the core of the body to start warming that person's body up. So again, heat packs, the neck, armpits, groin, sides of the chest. As far as active rewarming goes, we don't want to be like rubbing people up and down. You know how you might rub your arms or rub somebody's back, and we want to be, especially somebody who is very hypothermic. We want to be gentle with them. We'll get into that in a second, but basically we want to be gentle. So when we're actively rewarming somebody, we're not going to be rough with them at all. We actually want to treat them gently, so no like rubbing on them or anything else like that. Just apply like heat packs. Here is showing like another method of rewarming frozen parts here. So we'll get into this here in a moment. As an additional note here, as an edit, I wanted to mention though, we're going to actively rewarm alert and responsive hypothermia patients. So actively rewarm, apply heat sources to those patients who are hypothermic, but they are alert and responsive. Okay. We're going to passively rewarm hypothermic patients with any altered levels of consciousness. Okay, that includes being unconscious. Right. So active rewarm, people that are alert and oriented or alert and responsive, and passively rewarm those who have worse hypothermia, so those with decreased levels of consciousness. All right, let's talk about extreme hypothermia. These patients have been out in the cold or losing heat rapidly there for a while. They are severely altered in that they are unconscious and unresponsive. They may not have discernible vital signs. The heart rate can actually slow to like 10 beats a minute, and they're still alive. So if you have a patient that is unresponsive, they're cold to the touch, and you check their pulse, you want to do it for about 45 seconds, 30 to 45 seconds, because it may be weak and it may be very slow. 10 beats a minute, that's what, once every 6 seconds you get a heartbeat. So you want to take it for a little while. Okay, so 30 to 45 seconds. They are going to be cold to the touch all over, including in the abdomen there. If you don't have a discernible pulse, if you check that pulse and you can't feel one, start CPR, get the AED attached. If you do find a pulse, regardless of how slow it is, right, if it's 10 beats a minute, then we're going to care for them as we would any unresponsive patient, which means that we're going to be doing passive rewarming. If they're wet, get them out of those clothes, cut them off, dry them off, cover them with blankets, get them in the back of the unit, and then transport, obviously. Now, the body's metabolic processes slow greatly when you're cold. And so that's why somebody can still be alive at 10 beats per minute, very shallow breathing, slow breathing, very shallow, things like that. So there's a saying, it's you're not dead until you're warm and dead. Folks have been pulled out of like cold ponds and things like that, and an hour later, they've been under for quite a while, and they're resuscitated. So that cold can help maintain the person's viability for resuscitation. So don't stop working somebody. If you start working somebody, don't stop working somebody just because you're not getting them back, right? If you've been working them for 20 minutes, but they're still really cold, well, guess what? You're still going to continue to work these folks. All right, so that was generalized cold stuff. Now we're going to talk about localized cold injuries. The most commonly affected places are going to be on our extremities, fingers, feet, toes, hands, and then normally, even if you're all bundled up, you can have people have their faces exposed a lot of times. So ears, nose, cheeks, things like that. And we're on the face. Um, the blood flow is limited to these places because the body reacts to the cold by constricting blood flow to the extremities and to the skin of like the face there, and keeps it towards the vital organs to keep them warm and perfused. Now, when that happens, since there's no heat from the blood getting out there, the tissues can actually freeze. And when it freezes, the water, the intracellular fluids they freeze and they can form ice crystals, which damages the tissues there. Early freezing, it's called frost nip, and basically you remove the patient from the cold and you cover up that limb or the face or whatever it is, that area, you cover it up there. Late cold injuries, it's frostbite. Right? It's called late or deep. You have to cover it up and then immobilize it gently. You can be very, very gentle with frostbite injuries. So what do these injuries look like? How are we going to see them? So for an early or superficial or that frost nip cold injury, for patients with lighter skin, their skin is going to redden. In patients with darker skin, it can lighten. Um, After that, after the reddening or the lightening, then it's going to what's called the skin is going to blanch, which means it's going to whiten. Um, Once that starts to happen, it can happen really quickly, and then the area can feel numb to that patient as well. For the deep cold injury or the frostbite, late cold injury, frostbite, there, the skin is going to appear like white and waxy. Um, as it worsens, the skin gets it turns from like a white to like a grayish yellow until it finally gets to like a grayish blue. You may see some swelling and blistering there also. It's going to feel frozen, right? But it's mostly just like on the surface that feels frozen there. Um, so you have to be careful in touching them. So be very careful when you're handling frostbitten extremities. You want to wrap them and be very careful. With both of these injuries here, right, the frost nip or the early or superficial cold injury, as well as the late or deep or frostbite injury, uh, don't massage the area. Okay, don't massage the area there. Um, just again, be very gentle with the old ones or the deep ones there. Um, uh, you want to be very careful with that. In this picture, you can see the tips of the person's fingers had become frostbitten. You can see there's some white and waxy areas, and there's some of that bluish, grayish, like it almost looks like deep, deep, deep bruising there. His fingers, they got frozen pretty good there. Okay, for patient care, obviously get rid of all the wet clothing. Actively rewarm the patient during the transport if they are alert and responsive. Um, Again, that's putting ice packs at the junctional places, so the groin, neck, armpits, and you can put them on the sides of the chest as well. Provide care for shock there. You could have reason that to believe that they could go into shock. The reason that we do the warming at the junctional places instead of like along the arms or along the legs, let's say you start rewarming their legs, Well, what happens to the blood vessels? Well, they could dilate down there, and because of like the pressure differences and whatnot, we could have blood start to pool in the extremities. So you want to warm the core there. And if we have the blood pooling in the extremities with the blood vessels opening up like that, we could put them in a place where they'd be susceptible to different types of shock. If they're alert, you can give them some warm liquids, have them drink warm liquids there, and then transport the patient, unless it's a mild case. And what that means is if they're just shivering, then just get them warm and you may be able to get the refusal there. But otherwise, transport the patient if it's anything more than just shivering. All right, the patient is unresponsive. Make sure the airway is open, high flow oxygen. Um, if you if you've got a heater or a humidifier there for the oxygen, that's good. Sometimes what you can do is get a heat pack and coil the oxygen tubing around it a couple of times. That'll heat the oxygen up a little bit there before it gets to the patient. Wrap them in blankets. If you've got one of those space blankets, put one of those on first, and then the other blankets, and then get them to the hospital immediately. If they're unresponsive, that means that they're like severely hypothermic. And again, you have to be very gentle with these patients. If we're too rough with them, we can they can actually go into ventricular fibrillation. So you have to be very gentle. Just treat them with kid gloves. Be very, very gentle. Don't have them be active or walking around if at all possible. Okay. Get them on the cot. Use the cot as much as you can, or other transport devices, getting them to the unit there. Don't have them walking around. Don't have them doing much at all. Just laying there, and then treat them very gently. Okay, so actively rewarming frozen parts. Let's say somebody's got a frozen hand, or didn't have gloves or whatnot, and they're outside for a long time. It's not greatly recommended. There is a chance of permanent injury doing it happening there, and you really only do it when we've been directed by medical direction to do so. What you can do is put warm water in a container. The book says about 100 to 105 degrees, but what that basically means is that you want the water to feel warm to you, right? Not hot, but warm. Okay, water at about 100 to 105 is just over our body temperature, and it's going to feel warm, right? Not hot, but warm. That's what you want. So if you have like a trash can or something, a clean trash can, or bucket or something like that, you can fill it with warm water and put the frozen part in there. And it shouldn't be touching the sides or the bottom. Okay, you want the water to be able to circulate all the way around that limb if you're doing that. So don't have it touch the sides or the bottom. Remove any jewelry, watches, bands, straps, things like that. There's swelling could be happening there, so you don't want that to constrict any blood flow. So remove those things before you do it, and then make sure when you do dunk it into that bucket or trash can or whatever container that you have, make sure it's fully immersed. All of the frozen part gets in there. All right, and again, don't let it touch the sides or the bottom. We want all that water to be able to circulate around the entirety of the frozen part. If you need to, you can actually like stir that water a bit to circulate it. Don't touch that frozen part, but you can stir the water to circulate it for them. If that part gets rewarmed and the person's getting sensation back there, right, dry it off and then apply dry sterile dressing to it. Keep the patient at rest. Make sure that the ambulance compartment is nice and warm. Right, we want to make sure that the patient is entirely warm there. Continue to monitor them there, and obviously don't allow the limb to refreeze. Don't expose them to cold again. There, and then transport as soon as possible and elevate that limb a bit if you can. All right, let's talk about exposure to heat. All right, so we know that our body needs a certain amount of heat, and excess heat is usually um, uh, lost, right? We have body mechanisms to put excess heat out into the atmosphere there. It helps cool us off, so like sweating and things like that. Now, if the heat is not lost, if the body is not able to get rid of that heat, it creates what's called hyperthermia. So hyper, again, meaning above, therm meaning heat. So it's the body heat. It's above a normal body temperature. If it, as it says here, if it's left unchecked, it can absolutely kill your patient. There's a couple of layers here, so different levels of it. The first is heat cramps, and that'll lead to heat exhaustion. And then finally, there's heat stroke, the worst of the three, and we'll touch on all of those. All right, so there's heat exhaustion here, right? This patient is going to have moist and pale skin, or moist and normal skin there, or cool, or they may have cool skin as well. They're going to be sweating, okay? So that means that's why they're moist. They're going to be sweating still here. And part of the problem, what happens first is they'll get those cramps. And what it is as the body's sweating, it's losing the salts. And that when you lose a lot of salts, you get those muscle cramps. Okay, and so that would be like the first sign there of getting into heat exhaustion, is getting those heat cramps. Um, so even healthy people can exhibit forms of shock brought about by the fluid loss. So they're heavily sweating, they're hot, the body's trying to get rid of, and all of a sudden they don't have enough fluids in there. If they don't have enough fluids in their bodies for whatever reason, severe dehydration or excess sweating like that, what type of shock would that lead to? Hypovolemic shock it could lead to. A lot of times this is people that are, it's the first couple of days of it being hot, something like that, and they overexert themselves, so they haven't gotten used to the heat yet. Um, okay. Okay, so for our assessment for these folks, they're going to have muscle cramps. They'll have had them or continue to have them. Looks like they're continuing to have them. They'll be feeling very weak. They'll have rapid and shallow breathing. They're trying to put heat out. Their body's trying to get rid of heat through the expiration there, exhalation. They'll have a weak pulse, and they'll be heavily sweating. They can even, once they get into this heat exhaustion, they can lose consciousness as well. All right, so from our patient care here, get them out of the hot environment. Okay, if you're doing a standby at like a 5K, a local 5K or something like that, and somebody is doing this, and it's the middle of June or July, get them into the ambulance, with the AC pumped up. Get them out of that hot environment. Give them oxygen. Loosen or remove clothing if you have to, right? I can give them small sips of water. Place some supine there. That'd be easier for them. You can apply moist towels. You can put them in a bucket of water if you got big buckets of water or whatever there to try to cool them down there as well. So patients with hot skin, whether it's dry or moist, if it's hot, they're going to have it's the heat exhaustion. Right? They've gotten to the heat exhaustion there. They're losing the salts again as they continue to sweat. So think about it. If they're getting cramps because they're losing salt, is there any other important muscle in the body that might need salt to function properly? Pretty important muscle. How about the heart, right? So we can have problems arising from that too. But they can get those really painful cramps And we've already covered the other stuff there. All right, so for these guys in full-on heat exhaustion, they'll have rapid and shallow breathing. They're going to have a full and rapid pulse. Their skin's going to be hot, like we already said. They'll be very weak. They'll still be sweating, but a little bit at this point. They can be loss of consciousness or altered mental status, dilated pupils, and seizures. Get them out of the hot environment, remove their clothing, cool them off, apply cool packs. Just like we would actively rewarm somebody, we want to actively cool somebody here with cold packs in the junctional areas, so the neck, groin, armpits. Administer O2 and transport immediately. For kids, when you rewarm them, if you want to use water to help rewarm them, use lukewarm water. Right? And the reason is we don't want to cool them too quickly. If it's cool water, we don't want to cool them too quickly and then make them hypothermic at this point. All right, so there's places around here, and you can go work other places. There's water-related activities there, and you can have accents with any of them. So boating, water skiing, windsurfing, jet skiing, diving, scuba diving. You can all have accents with any of that kind of stuff. Obviously, we want to make sure that there's no airway obstructions, which means water here in the airway. It could be cardiac arrest, which calls it, signs of a heart attack there, injuries to the head and neck, right? If they're jet skiing and they wreck, something like that. If they dive into a shallow pool or pond or lake, river or whatnot. Obviously, if the mechanism of injury is enough, we can have the injuries to head and neck, internal injuries there as well. Now, if somebody's in water, it's usually a cooler environment unless somehow they slip and hurt themselves in a hot tub. So we can get hypothermic. Even on warm days, people can get hypothermic in water. There could be substance abuse involved, or somebody could have just drowned there, or a combination of a whole bunch of these things. All right, drowning, pretty awful way to go, probably. Your lungs fill with fluid, and so obviously you can't get oxygen in there. The outcomes are death there, usually, and so not a good thing to drown. So the WHO, as I'm sure you've heard about in the news recently with the COVID-19 stuff, the World Health Organization, they have a definition for drowning, and it's the process of experiencing respiratory impairment from submersion or immersion in liquid. And again, the outcomes that they prescribe are somebody either dies or there's morbidity, which means they don't die, but because water's gotten into the lungs, then they get pneumonia or other illnesses, or there's no morbidity there as well. What normally happens when somebody drowns is that they may be thrashing around, struggling to stay afloat, and as they start to go under, they try to take that one last breath there. If water enters the airway and gets past the epiglottis, it's usually like a small amount that will get down there into the lungs, and what will happen is, as a reflex, the epiglottis seals up the airway, and the person will basically die from the lack of oxygen there. So it'll seal up the airway so no more water gets down there. That's only a small percentage, though. It's about 10% of people. Everybody else is they'll go unconscious from a lack of oxygen, and when they do that, the muscles within like the epiglottis structure there relax, and then water flows freely into the lungs there as well. As we just said, when somebody drowns, they struggle. When they start to go under, they try to take one more breath. Water could enter the airway. When it does, you've all taken a drink and it's gone down the wrong pipe, right? Coughing, the involuntary swallowing of more water there, and then they may try to take that last breath when they're underwater. They may involuntarily take that. So again, as we said, some die from a lack of air. It's only about around 10%, but most people attempt that final breath, or they're unconscious and the water flows into their lungs there. What are you doing? Sorry, small person interruption there. All right, so if somebody's in the water and unconscious, they are unresponsive, you may need to begin rescue breathing in the water. Obviously, you can't do compressions if somebody's still in the water, but you can, if you're in there with them, support them in a semi-supine position, and then try to provide ventilation that way. Um, Once you get them on land, obviously you can do the whole CPR regimen, but don't delay getting those rescue breaths in there for them. You could encounter resistance because the stomach may be full of water, so there may be some gastric distension going on there. And so you may feel some resistance, right? That gastric distension is pressing on the lungs and things like that. There may be spasms along the airway um, there as well. So you may have to provide those breaths more forcefully than you normally would. Now, if somebody's got real gastric distension and it's really making it difficult to provide the breaths, what you can do is lay them left lateral recumbent or right lateral, either way. Have suction ready, and then place your hand on their epigastric region, right? So the top of the abdomen there, and you press in hard, and hopefully that's going to help to expel some of the water that's in there from their body. You can suction that out, clear the airway, and then try to get some breaths in there. And then obviously get these people transported immediately. All right, so if somebody has possible spinal injuries in the water, you want to assume unconscious people or people with head injuries, they have neck and spinal injuries as well. A note on the people that are unconscious, there may not be a mechanism of injury there. They may have just drowned, okay? Um, so just be aware of that. Um, when you have somebody that's like this, you want to start the resuscitation as soon as possible, even before you immobilize them, go backward. Right? So you'll have to start doing CPR, and you'll have to get them backward as you're doing it. Okay? Obviously, you'll need a team of people to do this. You're not doing it by yourself. But don't delay resuscitation to get them backward. Start immediately. You may not be able to get a good assessment on this patient in the water. It may be too difficult to do that, and so you may have to complete it after they are out of the water. Obviously, handle them with care. Don't aggravate any injuries if you can. But again, don't delay giving them CPR. If you can, try in all cases there with that unconscious or that head injury patient to keep their neck as straight as possible with the body's midline in a nice natural position there. It'll help in the long run. It may be difficult to do, but it'll help in the long run. And again, don't delay the resuscitation efforts in trying to do that. In caring for these people, there may not be a readily apparent mechanism of injury, so bystanders, any information that we got from dispatch that maybe the caller was aware of, will go a long ways into helping you assess this patient by figuring out if there was a mechanism injury or how severe that mechanism may have been. All right, for diving accidents, obviously if somebody dives in head first, we can get injuries that involve the head and neck. But there's also other injuries that can be involved there. hands, feet, ribs, things like that. The emergency care here is exactly the same for somebody that's got a head or spinal injury outside of the water. The only difference is we got to get them out first in order to immobilize effectively there. Scuba diving accidents. This is if you've ever heard of somebody getting the bends, this is somebody getting nitrogen bubbles in their bloodstream. It could be because of again, this may be due to bad training, a piece of equipment failed, holding their breath, some kind of underwater emergency, trying to conserve air. They've been too deep for too long, things like that. The decompression sickness, that's the bends. That means that our bodies have to get used to the pressure. It's much higher pressure the deeper you go, the more pressure is on your body. Like I'm sure all of us have been in a pool underwater where you had to pop your ears. That's because of the pressure difference. And so if they're really deep, let's say somebody's diving at 100 feet below the surface level, that's a lot of pressure that's on their body, and they can't just come straight up. Doing that, they get the decompression sickness. They get these nitrogen bubbles in their bloodstreams, which can do bad things to them. It can kill them. And they have to come up really slowly after being down there for that long. Signs and symptoms of the air embolism there, we can get blurred vision and chest pain. We can get numbness, tingling sensations, paresthesia in the extremities. They can be weak there, possible paralysis. And they can get a bloody sputum, so frothy blood in the mouth or nose there. And then they can even go into convulsions. Good times. It can get worse. They can rapidly lapse into unconsciousness, respiratory arrest, and cardiac arrest there. When you're seeing it, you can get personality changes, right? You're mean, angry, things like that. They can be very tired. They can have deep pain to the muscles and the joints there as well. They're going to look bad, so they'll have blotchiness or mottling of the skin. Again, numbness, paralysis. They feel like they're choking, coughing. The breathing can become labored. They can have like loss of muscle coordination, so that it looks like they're drunk. So they'll be staggering around. Again, chest pains and collapses that lead to unconsciousness and can lead to respiratory arrest and cardiac arrest. All this care is pretty simple and straightforward. Maintain an open airway. ABCs, right? Give them high concentration oxygen. If you know that they've been scuba diving in the last 48 hours and they're showing these symptoms, obviously give them high concentration oxygen, non-rebreather. Get them to the hospital as soon as possible. Now, you want to keep them warm, give them on their supine there, and monitor their vital signs. One thing it says here is you may want to talk to medical direction about which hospital that you really want to take them to. The reason for that is they may need what's called a hyperbaric chamber, and it's this chamber that they'll put the patient into, and they can slowly adjust the pressure levels that are on the patient there over a day or so or longer in order to relieve these symptoms. So they may be not all hospitals have them, so you may need direction on which hospital to go. So it's a good idea to figure out which hospitals in your area may have one, or where we may need to get a patient flown to. All right, water rescues. We're not really trained. There are people that are trained for swift water rescues and other kinds of rescues there. But this is going to be basically the extent of your training on it. So don't go out thinking that you're a lifeguard or something after you read a PowerPoint slide. All right, so here's the order of how you want to do things. So you want to reach for the patient. You can hold like a stick or a branch or something like that that the patient can reach, and you can bring them. They can grab onto, and you can bring them in with. There's the throw and tow. You may want to like throw a rope or an object that'll float to them, right? Like a life ring, something like that, or you throw um, a rope out to them. Next one, obviously, if you got a rowboat, why don't you row that boat on over to the patient, and then as a very last resort, then go. Right, you swim to the patient. This is dangerous because people that are drowning are often panicked. They may overpower their rescuers, and all of a sudden, there's not just one person that's drowning; there's two. So that is your last option, or is to actually go. Okay. And again, you are not a lifeguard after reading a PowerPoint slide, so don't think that you are. There we go. There's the reach, throw and tow, the row. Um, if you got your little inflatable boat and life vest, as our guy there has. All right, for ice rescues, the number one rule obviously is protect yourself, and that's the number one rule in all calls. So it's not different here. Um, throw a flotation device to the patient. Toss a rope. Try to tie a loop into the end of it, or not at least in the end of it, if you can. You want a loop because the patient can put it around themselves. They may have a really hard time holding onto the rope. Being really hypothermic, they may not be able to grasp onto things there. So with the loop, they can get it around their body. You can pull that. There's flat bottom boats. Fire departments will often have these in areas where they have water, ponds, lakes, etc., things like that. Or if you have a ladder, you can lay it flat against the ice. It helps distribute the weight so you don't fall straight in. Obviously, the patient's going to be hypothermic, right? So, try to warm them up. And again, as we just said, they may not be able to do much to help themselves out of that water. And so, just don't count on them being able to help themselves all that much. Always transport them if they've been in icy water. Don't work alone and don't walk on ice. Just don't walk on ice. Your weight is directly on these small areas, just your feet, and that can cause the ice to break there. So don't walk out onto ice ever. All right, real quickly, we'll do bites and stings. Insect bites and stings. All spiders are venomous there. So spider bites, they all are venomous. They can have all sorts of reactions there. Insect stings and bites, they're rarely dangerous unless we have somebody that is allergic and then anaphylactic shock becomes a concern. Then you want to remove the stinger. Generally, the method to remove a stinger is taking a card, like a credit card or driver's license, and then scraping the person's skin, generally what they say is away from the heart. So you can scrape it, the skin there until that stinger comes out. For a patient care, hopefully they're just going to be normal there. Maybe they've got a nice little bite mark, things like that. But if they've got an altered state of consciousness, that could change things for us a bit. They may have puncture marks there from teeth there or fangs. Note on the arms, forearms, toes, legs. Around the bite, you can get blotchy or mottled skin. You can have localized pain and itching and hives. Depending on the venom and things like that, you may have numbness or tingling in a limb or body part there as well. If it's bad, you can type of venom there. You can have burning sensation, followed by increasing pain levels, spreading throughout the limb, usually going back towards the body there. There'll be redness, there can be swelling and blistering. Once the venom starts circulating, obviously you can get very weak, you can collapse, you can have neurological issues. It's a neurotoxin, and so you have difficulty breathing, abnormal pulse rates, headache, dizziness, confusion, all sorts of just fantastic things for the patient to be going through at that point. Chills, fever, nausea, vomiting, muscle cramps, chest tightening, joint pains, excessive saliva, drooling, spitting, profuse sweating, and then obviously anaphylaxis has Big Daddy there problems. So for these folks, treat for shock, obviously. So lay them down flat, high flow oxygen, keep them warm, and transport. Call medical direction there. If you don't have specific protocols for doing that, get the stinger out, remove the venom sac if there's one hanging off of it. Figure out what type of animal or insect it was that bit or stung them. That is good to know. You don't have to be an expert on snakes. Neither does your patient, or insects, right? Neither does your patient. So size, color, any specific markings that were noticed, things like that. On the affected limb, if somebody got stung or bit on a limb, get the jewelry off of that limb. There could be swelling there, and the jewelry could restrict blood flow. Some places have what's called restricting bands, and so what it does is it basically will tourniquet above and below the bite. And what that does is it tries to prevent that those toxins, the venom, from spreading to the rest of the body if the local protocols allow for it. And then keep the limb immobilized. Probably also keep that patient from being too active. Keep them calm. Snake bites, they're usually not life-threatening, and death may take a while unless it's an anaphylactic response there. Keep the patient calm, you stay calm, keep them at rest. Immobilization bandage may be most effective there, so pressure bandage, basically tourniquet like we said. Pain and swelling could be in the area of the bite. You'll notice probably fang marks there around it. It could take a little while to develop there. You may see vital sign changes in rapid pulse and labored breathing, so they're working hard to breathe. As it progresses, as time gets further out from the moment of the bite, you can get progressive weaknesses, again, vision problems, nausea, vomiting, seizures, unconsciousness, the whole gambit here basically. And so again, it's important if we can figure out what type of snake it was. Again, treat for shock, keep them calm, locate the fang marks, remove jewelry, and immobilize those extremities that were bitten. Just as an addendum to the snake bite, if they've killed the snake, don't bring the snake head into or don't bring a live snake either into the hospital with you. They would probably not look too kindly upon that if you did that. So, if you have the headless dead snake, you may be able to put that in a bag so they can identify it and see what type of antivenom, if there is one, for that type of snake. Marine life poisonings, probably not going to get that around here. It can occur in a variety of ways. A lot of times salt water, spraying off with salt water will help, or vinegar also helps if you've ever gotten like sea nettles or jellyfish stings. And you spray them down with vinegar, it helps to relieve the pain there, neutralizes it. Fresh water doesn't really help. Salt water is good, and so is vinegar. Okay, there's a chapter. Um, make sure you've done your reading. And Friday, I don't know what the date is. Um, Friday, April 10th, 2 p.m. We'll be having a well, meet and greet to discuss anything in these chapters. Please make sure the pre-test and the homework are done. The test for this chapter is due April 11th at 23:59. All right, thanks, guys.